We have no disclosures. With decreasing hospital resources and increasing medical costs, a safe reduction in postoperative length of stay has become a major focus to optimize healthcare utilization. Initiatives aimed at reducing length of stay, including the expanded use of laparoscopy and enhanced recovery pathways, have been adapted and proven to fast-track recovery after major colorectal surgery. Despite these efforts, patients continue to unexpectedly fail early discharge. Furthermore, these patients use a disproportionate amount of healthcare resources. The aim of this study was to evaluate patients who underwent elective laparoscopic colorectal surgery and failed early discharge. In our institution, the majority of patients are discharged by postoperative day 3, so we define less than or equal to 3 days as early and greater than 3 days as delayed discharge. Our primary outcome was to identify the distinctive variables between the early and delayed day of discharge groups, and our secondary outcome was to use these variables to predict the day of discharge. To this end, we reviewed a prospective IRB-approved departmental database for all elective major laparoscopic colorectal procedures over a 3-year period. Patients were divided into early and delayed day of discharge groups. All cases followed a standardized, well-implemented enhanced recovery pathway. We compared our groups using univariate analysis, then developed a logistic regression model to predict the probability of delayed discharge using the basic demographic, procedural, and outcome variables. 548 cases were included in the analysis. The groups were similar in age. However, the delayed discharge group had a significantly higher BMI, Charlson score, ASA class distribution, and rate of previous abdominal operations. The main indication for surgery in both groups was colon cancer. And the main procedure performed was a segmental colectomy. There were distinct differences in short-term outcomes between both groups. In our delayed day of discharge group, the operative times were significantly longer. There was more blood loss and subsequent transfusions required. Our readmission rate was similar between both groups. However, the delayed discharge group had a higher rate of complications overall and unplanned reoperations. The complication profile was also dissimilar across the two groups. In our early discharge group, the most common complication was dehydration, while in the delayed discharge group, the most common complication was a bowel obstruction, and there were higher rates of all major complications, including deep infections requiring drainage and ostomatic leaks and bleeds. As expected, the total direct hospital costs were significantly higher in the delayed discharge group, and more of these patients required home care or skilled nursing at discharge. The patient demographic and outcome variables were formulated into a full logistic regression model with length of stay as the response. In our final model, we found that the variables that impacted length of stay were operative time and case status, elective or emergent. For every hour of operative time, the probability of delayed discharge increased by almost 2.5%. And for every emergent case, the probability increased approximately 14%. Since operative time was our only modifiable factor, we used this model to graph length of stay versus operative time. As you can see here, our straight continuous line supports the validity of our model. And at a time of 0, there's no additional effect on patient length of stay. But at 4 hours of operative time, there's almost a 10% probability of delayed discharge, and that's with all other factors being controlled. So in this study, we identified that there are distinct preoperative, perioperative, and postoperative factors in patients that fail early discharge. Patients with longer operative times and more comorbidities are more likely to fail. For these patients, early discharge may not be achievable, and practitioners should have different expectations of an enhanced recovery pathway. Adjustments should also be made to discharge criteria with emphasis on the factors that can be optimized, such as operative time. Further, by identifying these patients at risk for failing, resources and postoperative support can be better allocated. Thank you.
Dr. Keller, that was very nice. It really defined two different populations here that you can work with. I think you were a little defeatist in your conclusion in that we can't change, maybe we can't change that group. Were there some factors that you identified in that greater than 3-day population that preoperatively you may have been able to manipulate or precondition or identify those ahead of time to try to jump them into the other group?
Absolutely. That's a great question. I think that a lot of the demographic factors are things we could recognize in clinic because these patients have more comorbidities, and we would expect them to have longer hospital stays with that. Higher ASA scores, higher Charlson Index scores.
Mm-hmm.
Sorry, Felipe Velulio from Chile. I have a question. Great presentation, by the way. I noticed that the main cause of rehospitalization in the early discharge group was dehydration,
Yes.
right? Those patients had an ileostomy, and if that's the case, do you have some sort of ileostomy pathway? How do you take care of that, or do you realize that that's something you need to change?
Only a small amount of those patients had ileostomies. In general, we do not have a separate pathway for ileostomies, but we have identified that ileostomy and ileostomy reversal patients do have higher complication rates, so that's something we're looking into.
We have two questions by text. The first is whether the patients received Entereg, and if so, how does Entereg affect or improve postoperative course?
Entereg is for open. We use it for open. We use Entereg in our open cases. It's been proven to help open cases more than laparoscopic cases, but it is part of our pathway preoperatively.
Just as a comment, so we've published 2 papers on Entereg in laparoscopic cases. One is a national database analysis, which was in the Annals last year. And interestingly, when you look nationally, Entereg appears to be associated with a slightly shorter length of stay. So we also looked at about 150 case-match cases of our own who were already on an enhanced recovery pathway to see if Entereg would improve the outcome. And in the settings of our practice with our enhanced recovery pathway, it didn't give an additional benefit. So we haven't used it since. The second question, Debbie, was TAP blocks and the effect of TAP blocks.
TAP blocks, we are actively publishing on and doing a randomized trial on. TAP blocks have decreased our length of stay and are part of our pathway when possible.
But we wait the randomized control trial.
So
Sir,
we
the
wait
front
the
mic.
randomized control trial.
Rafael Garcia from Colombia. Do you do bowel prep to all your patients, or do you think that influence in the outcome, in the early outcome of your patients?
You just selectively prep your patients. We selectively prep our patients.
Back mic.
Instead of using Entereg, which is expensive, did you consider chewing gum?
We do
Consider-
use chewing gum. It's actually part of our enhanced recovery pathway postoperatively. All our patients get chewing gum.
All right, thanks.
Okay, thank you.
Thank you, Debbie.